Hi, everyone. We're just getting everyone in the room to start the webinar shortly. And we're getting up in numbers, so we'll get started. Welcome, everyone, to today's roundtable with Dr. Lawrence Afrin. We are Renegade Research. We are a decentralized patient and caregiver-led nonprofit research organization, and we have these roundtables in order to expand the pool of clinicians that are treating ME/CFS, long COVID, and infection-associated chronic illnesses. So thank you very much for being here today. Thank you to our staff and volunteers for making all of this possible. And I'll pass it on to Rochelle.
All right, so for today's webinar, our Q&A session will be at the end of Dr. Afrin's presentation. He does have a hard firm stop at 2:30 Eastern time, so we will make sure we're wrapping it up by then. Any questions not answered in this, we can address in part 2. If you haven't signed up for that, we will put the link in the chat. If there's anything the panelists can answer, they will go ahead and try to do that for you. So that way we can have those kind of filter out the questions that'll be the ones that'll be the most useful to for having Dr. Afrin answer. And that you can upvote them. So we can get kind of help to streamline which ones will be the highest priority to answer. And with that, when we get to the Q&A session, what we'll do is we'll bring you on to answer your question. And if you're not still on at that point, or if you just don't answer your question, then one of the panelists will ask it for you. Anyway, so we'll go ahead and I'll turn it over to Ellie, and she will introduce Dr. Afrin.
Okay, my name is Ellie Brocious. When Dr. Rowe was here in February talking to us, he mentioned Dr. Afrin and his work on MCAS, and he graciously connected me with Dr. Afrin, who, after training at the Medical University of South Carolina, practiced and researched hematology and oncology. Since about 2005, his clinical research work has come to focus on mast cell disease. After some time in Minnesota, Dr. Afrin has been developing an independent institute located in the greater New York City area for advancing care, research, and education in mast cell disease. His publication record includes some of the most highly accessed articles about MCAS and a popular book in the field called Never Bet Against Occam, Mast Cell Activation Disease, and the Modern Epidemics of Chronic Illness and Medical Complexity. Dr. Afrin, please take us through MCAS 101.
Sure. Thank you very much, Ellie, Isabel, Rochelle, for the opportunity here. Let me share the presentation screen. You guys seeing this?
Yes.
Okay, great. So again, thanks for the opportunity. We're going to talk today sort of an overview, general understanding of mast cell activation disease, current concepts in this area. The objectives will be to review basic concepts regarding the overall class of mast cell activation disorders, spending most of our time talking about sort of the new kid on the mast cell activation block, or Mast Cell Activation Syndrome, MCAS. We'll spend much of the time talking about the clinical presentation of MCAS, and briefly at the end, sort of a 100,000-foot view to diagnosing and treating it. But the subsequent presentation will go in a whole lot more detail about diagnosis and treatment. Have no conflicts of interest to declare, but just please note that any treatment options mentioned here in the subsequent presentations, by definition, are ACCME level of evidence C, consensus viewpoint, or expert opinion, because there just aren't any robust clinical trials yet to give us science for directing treatment at this point. Is mostly clinical art and experience. So we'll spend just a little bit of time up front talking about what we've long known in the area of MCAD, that is the allergic diseases, and the very rare disease of mastocytosis. We'll spend the great majority of the talk talking about MCAS. And at the end, just a moment on potential research issues. So I want to start helping the audience, which I understand is largely clinicians today. And by the way, if my new friends from Trinidad are in the audience, as they had led me to expect, shout out to them. You're my first contacts in the Caribbean. Glad to meet you. I think it's best for clinicians to come at this by first having some cases presented at you that turned out to really have MCAS at the root of them. And one of the biggest challenges a clinician typically has in coming to understand this disease is just how incredibly heterogeneously it presents. It can really present in polar opposite fashions on any given biological parameter in the human body. And so let's take that approach and present first a couple of cases. My very first case, actually, who came to me misdiagnosed, actually, with polycythemia vera, a rare cancer in which you're overproducing red blood cells. And then my second case, in whom I came to recognize MCAS was at the root of it, she had what superficially appeared to be the polar opposite problem of pure red cell aplasia, where the marrow completely gives up making red blood cells. And I don't want you to go away from the talk, come away from the talk today thinking, oh, every MCAS patient has hematologic issues, because in truth, most of them don't. But to further illustrate the extreme heterogeneity of this, I'll briefly add in a third case in a completely perpendicular direction, somebody who came to me with a diagnosis of something I had never even heard of before, called burning mouse syndrome. So let's dig into it here. The lady with P. Vera, up until her 30s, had a pretty unremarkable past medical history. And then in her 30s began noticing a migratory rash. This hard-charging, independent small businesswoman over time began noticing more sort of constitutional and neurologic problems, fatigue, itching, vertigo, falls. Occasional evaluations were negative. Again, kind of stoic woman, didn't pursue evaluation all that much. Finally, the fatigue got so bad, she went back to her internist in 2005. She was in her, I guess, early to mid 50s at this point, probably early 50s. And with the fatigue, the internist, of course, checked a CBC, expecting to find she was anemic. And to his surprise, he found the opposite. She was mildly polycythemic. And so she got referred to the local hematologist, who at the time, unfortunately, ran sort of an incomplete evaluation for PV and prematurely diagnosed polycythemia vera, PV, and then began giving the standard treatment for that, therapeutic phlebotomy, draining the excess blood out of her. And you'd like to think that if you're given the right treatment for the right diagnosis, the patient ought to get better, but she actually just kept getting worse in a myriad of different fashions, as you can see described here. She kept begging for us to be referred for a second opinion. The hematologist said, no, here we absolutely have the right diagnosis. And finally, in fact, he actually doubled the intensity of the phlebotomy. He was so sure he had it right, and she just kept getting worse. Finally, she self-referred and wound up in my clinic. I was kind of my clinic at the nearby academic medical center. I was kind of the dumping ground for the mystery cases in my division at that time. And it only took 60 seconds of history to figure out she couldn't possibly have PV. I'm a hematologist. I know PV. I know the way that disease behaves. And yeah, she had a mild bit of polycythemia when she initially presented, at least until all the phlebotomy made her anemic. But she had a bunch of other things going on that PV couldn't possibly account for. So the question became, what the heck do you have that can be causing not only a little bit of polycythemia, but also all these other symptoms? So at the time, I ran the testing that had become available, the genetic testing that had become available to pretty specifically diagnose PV, the JAK2 mutation analysis. Unsurprisingly, that was negative. And so what else do you have that could be accounting for all this? And right from the first visit, actually, there were some things about the presentation that had me kind of suspicious of the only mast cell disease I knew of at the time, mastocytosis. But I ran the testing I had been taught to run for mastocytosis. Tryptase was normal, N-methylhistamine was normal, marrow biopsies were normal. These intermittent rashes, I even had the rash biopsied, and it was negative. And I considered a lot of other diagnoses over the months, but it just kept circling back. It just kept smelling like mastocytosis. I kept reading more and more about this disease that nobody ever really spent any time teaching us about, and learned about more testing I could do for this. Finally learned about this metabolite prostaglandin D2, pretty specific to the mast cell. I tried to measure that. I made every mistake one can possibly make in measuring prostaglandin D2, pretty technically challenging to accurately measure. Finally, I fixed all the mistakes, and lo and behold, found an elevated prostaglandin D2 level. I called her in and said, well, I think we're heading in the right direction with the thinking of mastocytosis, but I'm an oncologist. You don't diagnose a cancer without finding the cancerous tissue somewhere. So we had to go biopsying something. Thought about the options, finally decided, I already done the marrow and the skin, that was negative. So thought about it, did some reading, finally decided to biopsy the GI tract, sent her off for that, upper and lower scopings, and the pathologist told me that everything looked textbook normal. And I asked him, did you do this special staining that has to be done to see the mast cells in there that we had discussed in advance of the procedure? And I said, no, I didn't do it because I'm telling you, it looks completely normal. I said, I don't care. There's got to be something here that we're just not seeing on routine evaluation. Please go do the special staining. He argued with me. I argued back. I won. He went and did the staining, and then called me about 3 weeks later and kind of stuttering said, I've never seen anything like this before, because like many pathologists, there's 2 microscopes in his office. And on one microscope, he had the routine hematoxylin and eosin stain, the H&E stain, which, as you can see here, looked completely normal. And on the other microscope, he had the CD117 stain that he said just a bunch of mast cells here. Nothing close to what mastocytosis should look like, but clearly abnormal. So I called her in and I said, I don't know what to call this other than atypical mastocytosis. And there's no guidance in the literature about how to manage this. But so we talked about options and ultimately decided, because of just how atypical a case she was, we were learning at that point some new stuff in the literature, that this wonder drug for chronic myelogenous leukemia, CML, this wonder drug called Imatinib that had just come out a few years before, did a great job in CML. We were starting to learn that even though most cases of mastocytosis were utterly refractory to Imatinib, that it was the odd or unusual cases of mastocytosis that seem to have more of a likelihood for responding to this extraordinarily expensive drug. So I said, what the hey? And we tried it, or there was no dosing guidance available. I started with the lowest available dosing, just out of safety interests, and took a guess that after a week at the lowest dose, if you know better, but you're tolerating okay, then double it and come back in a month, and we'll go from there. And she came back in a month, and I walked in the exam room and did a double take. She had been dragging her butt into the office every month for this nearly year-long workup, just utterly bone weary of fatigue. And here she was, sitting there beaming, radiating energy. And I said, my goodness, what the heck happened? What'd you do? And she said, I did what you told me to do. She said that you clinicians in the audience, remember how we get taught in training that with most drugs, it's 4 half-lives to get to a steady state? Well, imatinib's got a half-life of close to 24 hours. So she took it the first 4 days, 100 milligram dose a day in the morning, didn't notice anything. Then she woke on the morning of the 5th day, with the plasma level of the drug that's notched up just a little bit further. And I mean, she had been waking every morning for years at that point, just utterly exhausted. It took her 2 hours every morning just to crawl out of bed. And she woke that morning and just instantly aware, the moment she awoke, just lying there in bed, hadn't even moved yet, that all of her symptoms were gone. And she leaped out of bed, and bottom line, she's been running like a rabbit ever since. She had previously had to close her business. She was so sick, and she was able to resume her business and get back to exercising. It was really a remarkable response. Once she kicked up the dose to the 200 milligram level, and after 4 days at the 200, that 5th day she just awoke. It was your proverbial miracle, and that improvement has basically been sustained. I think it's more than 13 years now. Now, literally the next day after I saw that initial response, I saw another new consult, a lady who came to me for exactly the opposite problem. Pure red cell aplasia she had had for several years, certified with that diagnosis by 2 different academic hematologists, 3 different community hematologists. Every potential cause had been assessed. She was negative for all that. She was refractory to all standard treatments. She was intensively transfusion dependent, 2 to 3 units of blood every 2 to 3 weeks. Of course, she got hemosiderosis, which only complicated things further. And to this day, I'm really not still quite sure why she ultimately came to see me. I had no name in PRCA, but I guess I was the dumping ground for the mystery cases. So I saw her for an initial consult, and thanks to all that I learned about mast cell disease in the context of the first patient, I quickly realized that, yeah, she had the anemia, the severe anemia, and all the symptoms you'd expect of that, but she also had 497 other symptoms that severe anemia couldn't possibly account for. So, and everybody else had been ignoring all the other symptoms because they couldn't figure out how to make it all fit together. So, question became, what do you have that can cause not only severe anemia, but also all these other problems? And I began to wonder, well, since every other conceivable diagnosis has been ruled out of you, maybe what's going on here is just another form of this atypical mastocytosis, but impacting the bone marrow in completely the opposite fashion. So I did the testing that I'd gotten better at doing by that point, looking for this atypical mastocytosis. Yeah, she had a high prostaglandin D2 level, and we made the diagnosis that was just coming into the literature at that point, Mast Cell Activation Syndrome, because it clearly was not mastocytosis. And with antihistamines alone, I actually got her off transfusions, up from a hemoglobin of like 5 up to about 8. In just a month's time, transfusion independent. And that's a lot better, but still far from a normal hemoglobin. So I tinkered with some other mast cell targeting drugs, didn't get anywhere. Finally pulled that expensive trigger, put her on low dose imatinib, and in just a month and a half, her hemoglobin was 13. We actually lost that response. She settled back down to a hemoglobin of 8 about a year later, but she had switched insurance companies at that point. And even though the first insurer had not allowed me to try the much cheaper, I mean, still an expensive drug, but relative to imatinib, much cheaper drug of cromolyn, nobody ever said insurers are smart, but the first insurer didn't allow me to try cromolyn, but the second insurer did. So at that point, having lost the response, but a new opportunity to try another mast cell targeted drug. So I tried her on cromolyn, and again, got a hemoglobin of 13 in 4 weeks, and all the other symptoms, or at least most of them, got better too. Now, to this perpendicular direction, again, don't go thinking all these patients have hematologic issues, because most of them don't. But at the time I was evaluating the first 2 patients, I had already been working on this lady. for about 4 years at that point. Middle-aged woman who fairly acutely in her early 50s started develop this severe burning pain, by far the worst in the mouth, but she really had it all throughout the GI tract. Hell, her pain was like 11 out of 10 every waking moment of every day. How in the world she didn't commit suicide in the years she had the pain, I don't know. But she spent the first year, extensive evaluations, every specialty. Nobody could figure out what was going on. Finally saw an enterprising endocrinologist who wondered, maybe there's just a weird neuroendocrine tumor going on here. Checked the chromogranin A level, found it was 100-fold elevated, and she didn't have any of the other confounding factors for that. And so, gosh, you must have a neuroendocrine malignancy. So off to oncology she goes, into the lap of the dumping ground for the mystery cases. And I walk in the exam room. And again, this is like 4 years before my the polycythemia case. And I walk in the exam room, and yeah, there's no question she's in a lot of pain from the burning in the mouth. But if you have 100-fold elevated chromogranin A level due to a neuroendocrine tumor, you have an advanced neuroendocrine tumor, and you ought to look like an advanced cancer patient looks. And she was in pain, yeah, but she didn't look anything like she had advanced cancer. So nevertheless, I didn't know anything else that could cause such a humongously elevated CGA level. So I did all the testing I was taught to do to look for neuroendocrine malignancies. Couldn't find squat. Consulted the top 5 neuroendocrine cancer experts in the country. They all congratulated me on the thoroughness of my workup and said, we don't know why the testing's negative, but there's nothing else that can explain it. It's got to be a neuroendocrine tumor. So they actually unanimously recommended just repeating the same set of $50,000 set of tests every 6 months, and they said it'll show up at some point. And that just sounded crazy to me. I did not do that. You don't want to know about all the other crazy diagnoses I considered over the next few years. But finally, in the context of coming to understand the mast cell disease in the PV and the pure red cell aplasia cases, I began wondering whether the lady with burning mouth syndrome, which apparently is a prevalent disease, 1% of everybody in the country has got chronically burning mouth, and most docs don't know about it because these patients rapidly get shunted to the dentists and the oral surgeons who hate seeing these patients, don't know what to do with them, can't ever find anything wrong with them. They think it's all somatic, psychosomatic. So I began wondering whether this lady with BMS might have just another variant of MCAS. So, she, of course, had multiple endoscopies done, trying to figure out why the GI tract was burning. Everything was normal. So I called up the pathologist and said, look, you got to dig up those old biopsies. And, thank goodness pathologists hang on to the old biopsies for long times. And I said, you got to go do the 117 staining. And so he did that. And sure enough, there it was. And so just with antihistamines and NSAIDs, pain dropped from 11 out of 10 to 1 out of 10 overnight. I called up her chief oral surgeon, said, do you have any of these BMS patients? And he said, oh, yeah, I got a ton of them. Hate seeing them. They're all crazy. Nobody knows what to do with them. And I said, well, I got an idea. Why don't you send me a few? And he was only too happy to do that. And I started evaluating them. And yeah, they had markers for mast cell activation in different patterns in different patients. But fundamentally, every single one of them turned out to have MCAS. And that was actually the subject of one of my earlier papers in this area. And they all responded to various mast cell targeted therapies. So, highly divergent presentations, but ultimately just different variants of the same root disease. So how is it possible for one disease, so to speak, to present so with such extreme heterogeneity, and could other weird presentations be possible? And we'll get to the answers to those questions in a few minutes. But before we go into that, it helps to first understand where we've come from in this field, what we've come to understand so far about the mast cell disorders, starting with the most prevalent group of mast cell disorders, by far the allergic diseases, allergy, asthma, so forth, as you see here on the slide. These are very prevalent diseases. About 10 to 20% of the entire world population at this point suffering allergic type disorders of one sort or another at this point. We know the incidence and the prevalence of these diseases has been increasing in the modern era lots of theories about why that might be happening, possibly genetics, possibly environmental exposures. Nobody's really pinned it down yet. We know these diseases are conditioned by genetic and environmental factors, but fortunately, most of these patients have a normal lifespan, relatively little mortality, except for, unfortunately, the occasional fatal anaphylaxis. But you can't deny, even if there's little mortality, that there often are significant quality of life effects here. So you got to make the right diagnosis and apply the right treatment to give the patients a better quality of life for a normal lifespan. Now, contrast the prevalence of the allergic disorders with the extreme rarity of the only other disease of the mast cell we had previously known about, mastocytosis. First discovered actually in the 1860s in the form of this weird rash, this urticaria pigmentosa. I was showing pictures of over on the right. It actually took another decade before the mast cell itself was discovered, and another decade after that before it was realized that UP actually is a malignancy of the mast cells. Another half century before we realized mastocytosis could be causing not only cutaneous disease, but also internal disease. That's the decade, the 30s, when we began identifying various mast cell, the various mediators that are produced by the mast cell, starting with heparin, actually. It was the 80s, another half century before we started classifying mastocytosis in different fashions, and that's the same decade in which tryptase was first identified. And actually, the very first case reports of what we now call MCAS actually crept into the literature at that point. It wasn't called MCAS back then, of course. In the 90s, a couple of Japanese groups simultaneously identified the codon 816 mutation in KIT, transmembrane tyrosine kinase receptor KIT, that's present on the surface of the mast cell tenfold more brightly than on any other type of cell in the human body. And this one particular mutation is found in more than 90% of cases of mastocytosis. There was a Spanish group a few years later identified a unique flow cytometric signature for identifying mastocytosis. And 2001 actually was the year that the WHO's classification system for mastocytosis first emerged, and we've been using that system ever since for categorizing mastocytosis. And coincidentally, that was the same year that the wonder drug Imatinib came out for CML, and it was only a few years later before it was before some smart people figured out that low doses of much lower than you use in CML, actually can be spectacularly helpful in the rarest of these rare patients with mastocytosis who are actually presenting without the codon 816 mutation. And so in the last 20 years, it's come to be understood that the cancer of mastocytosis is kind of an unusual one in that all the symptoms you get from mastocytosis, they're not coming from the bulk of expanding tumor. Rather, the symptoms of mastocytosis are all coming about from the inappropriate activation of these neoplastic mast cells, the inappropriate production and release of all these mediators that are produced by the mast cell. That's what's causing the symptoms of mastocytosis, and that's quite different from how the bulk of other cancers is what's causing the symptoms in those other cancers. So this is the spectrum of mast cell disease we've long known about, this mountain of disease. This is not drawn to scale, but you get the picture that the majority of the mountain are the allergic type disorders, and at the tip of the mountain, you got this tiny population of mastocytosis patients in different forms, cutaneous being the more common, typically seen in childhood, and the even rarer systemic mastocytosis, typically seen in middle or older age. So the whole mountain features inappropriate mast cell activation, but it's just the tip of the mountain, the mastocytosis patients, who additionally feature inappropriate, kind of grossly neoplastic proliferation of the mast cells. So that's the spectrum of mast cell disease we've long known about. So now let's look at the history of mast cell activation disease. So again, the first published hypotheses that there ought to be a disease in which you have inappropriate activation of the mast cells with little to no proliferation of the mast cells. That popped into the literature in the 80s, but fast forward more than 20 years before we get the first actual case reports of MCAS. And that same year, we had the first study out of the University of Bonn showing that actually the vast majority of MCAS patients do not have that codon 816 mutation in KIT. They almost all have a bunch of other mutations in KIT, but they usually don't have the codon 816 mutation that you almost always find in mastocytosis. And from that point on, a number of studies began finding a lot of other mutations and a lot of other mast cell regulatory genes in not only mastocytosis patients, but also MCAS patients. In 2010, we had the second study, again demonstrating plenty of KIT mutations, just not the codon 816 mutation in most MCAS patients. And that study actually also did this sequencing in healthy control patients and show they don't have these mutations. So it becomes pretty obvious it's the mutations that are driving different mutations, different mutational profiles driving different patterns of misbehavior in these different patients with mast cell activation syndrome. That same year, 2010, we had the first proposal in the literature for diagnostic criteria for MCAS. Actually, we had the first proposal to reterm this whole area of disease from just mast cell disease to mast cell activation disease upon the new recognition that first and foremost, what's driving all the symptoms in these patients is the activation. And that paper had the first proposal for specific diagnostic criteria for MCAS, but there were a lot of problems with that proposal. So a few months later, early 2011, an alternative proposal came out. And in all fairness, full disclosure, I was one of the ringleaders on that one. Both proposals have gone through multiple reassessments over the 14 years since. The first one, in my opinion, a lot other opinions too, remains quite problematic. That's come to be called the Consensus One proposal, and the latest revision in 2019 is really not any significantly different than what was first proposed. The alternative proposal was retermed in 2020, the Consensus 2 proposal. The WHO back in 2016 actually put out its latest revision of diagnostic criteria for mastocytosis, but they saw at the time there was all this controversy about diagnostic criteria for MCAS, and they wisely just stayed out of it. We'll see if that continues to be the case when they come out with their next revision of the criteria for mastocytosis. So this is the new understanding of the total landscape of mast cell disease. The mountain we were seeing before is now understood to itself be merely the tip of a veritable iceberg of disease in which the portion of the iceberg we can easily clinically recognize above this waterline of easy clinical recognizability, that's all the mast cell disease we previously knew about. But submerged below this waterline of easy clinical recognizability is this vast pool, this vast collection of mast cell activation syndromes not yet otherwise classified. And now it's understood that the whole iceberg features chronic inappropriate mast cell activation, while just the tip of the iceberg features the cancerous proliferation of the mast cells we call mastocytosis. So it's now understood that, yes, mastocytosis remains the extremely rare disease we always knew about, but MCAS is turning out in repeated studies now to be quite prevalent, roughly 17 to 20% of the general population. Just as you might imagine, since it's not being taught yet, since few doctors have learned how to recognize it yet, the truth is it's being seen every day by every doctor. You just can't recognize it for what it is because you haven't learned yet that it exists, haven't learned yet how to recognize it. but it doesn't change the fact of its existence and its prevalence. A few other quick things about normal mast cell biology. These cells are born in the bone marrow, but they pretty quickly leave the bone marrow, enter the circulation, don't spend much time in the circulation, quickly exit into the peripheral tissues where they complete their maturation. They are present in all tissues in the body, pretty sparsely distributed in most tissues in the body. Where they're dominantly sited is at the environmental interfaces. So the skin and other aspects of the integument, the respiratory tract, the GI tract, the GU tract. So they're at the environmental interfaces and directly abutting all vessels and all neurons. And this is where you'd expect them to be primarily situated in order to best serve their principal role in human biology, principal role in the immune system of being the frontline sentinel, alerting the body against any attacks, any insults upon the body. I mean, the lymphocytes take hours to activate upon an insult. The neutrophils take minutes to activate. The mast cell activates in sub-second time. There's no other element of the immune system that activates anywhere near as rapidly as the mast cell does. These cells are relatively immobile. They got a minimal amount of chemotactic ability, but relatively immobile once they're in the peripheral tissues. Typically live about 2 to 4 years, but some of them can live a good bit longer or a good bit shorter than that. Their primary role is to synthesize various active substances, what we generically call the mediators. Some of the mediators are pre-manufactured, stored in granules inside the mast cell, so they're available in relatively large quantities for immediate release upon certain insults. Other mediators, in fact, most of the mediators are just manufactured on demand. And so they manufacture these mediators, store them, and they release various mediators upon various triggering. Another thing you need to understand about normal mast cell biology is that normal numbers of normally structured, normal functioning KIT, this transmembrane tyrosine kinase receptor at the surface of the mast cell, again, tenfold more brightly on the surface of the mast cell than any other type of cell in the human body. You got to have normal numbers of normal functioning KIT to have normal mast cell function, including normal survival and normal activation. This is the obligatory, molecular pathway cartoon showing that when the natural ligand for a homodimer of KIT, the stem cell factor is a natural ligand for this homodimer of KIT, and when SCF binds with that receptor, you get immediate change in the the three-dimensional conformation of the intracellular domain of KIT. And this conformational change in KIT is then what immediately activates a wide variety of downstream pathways, like the JAK-STAT pathway, the RAS-MEK-ERK pathway, and so on and so forth, that are instrumental in all these normal functions of survival and activation. And believe you me, this is a grossly oversimplified cartoon. So we used to think that the way that mediators get released from the mast cells is just the traditional fulminant degranulation process, but we've learned over time there are plenty of other ways too that mast cells can release their mediators. This video from Pete Smith at Griffith University in Australia shows how these granules can migrate up the microtubules to the cell surface, fuse with the cell surface, and exocytose their mediators. So what triggers mast cells? We all learned in training that you got these high affinity receptors for IgE type antibodies that are sitting on the surfaces of the mast cells. And anytime a molecule, an allergen comes to cross-link IgE antibodies for that allergen, IgE antibodies that have been pre-bound to IgE receptors on the surface of a mast cell, that binding immediately activates the mast cells, but it turns out there are an awful lot of other ways to activate the mast cells. Plenty of other receptors on the surface of the mast cell. It's not just IgE receptors. The mast cells have been found to have more than 300 receptors on the cell surface. Sorry, don't know why it's going ahead like that. So you got receptors, all the different types of histamine receptors. Of course, KIT is the receptor for SCF. Receptors for all the different types of immunoglobulins and complement, platelet activating factor. CRF is an interesting one. Corticotropin releasing factor comes out of the various organs in the body instantly whenever we're subject to stress. And we've known for decades that stress, whether physical or psychological, is a major trigger for activation of the mast cells. They've also got receptors for a wide variety of neuropeptides and opioids, paralytics, believe it or not, benzodiazepines and cannabinoids, and they've got plenty of toll-like receptors. That's what's give them the ability to recognize the invasion of various microbes into the body. And not only all those receptors, but they can also really got a number of mechanisms for responding to various physical stimuli, physical forces as well. So just to illustrate how vigorously these cells can activate, this is a video microscopy courtesy of Theo Harides at Nova Southeastern University, international expert in mast cell disease. This is what happens when a single molecule of substance P comes to dock with a substance P receptor on the surface of a mast cell. And there you go. You see how there's just this explosive outpocketing from the mast cell. This is the degranulation. Just happens explosively when these cells get triggered. So these cells are capable of synthesizing and releasing many mediators, and you got a listing of some of them here. This is in a font that's almost too small to read, but that's kind of the whole point, because even this listing of, I don't know, 30, 40 mediators is itself only a tiny subset of what we've now come to understand is actually more than 1,200 mediators these cells have been cataloged to produce, each of which causes a huge array of downstream effects in various tissues in the body. So in the same fashion that molecular scale transistors through appropriate amplification mechanisms can exert impressively macro scale effects, this is what's basically going on with a small quantity of these very potent mediators getting released from a small number of dysfunctional mast cells, but through appropriate amplification mechanisms, you can wind up with horribly severe symptoms of a wide variety of sorts, depending on which mediators are being inappropriately released. So these are the diagnostic criteria out of the WHO for mastocytosis, and they do a great job for fairly specifically identifying cases of mastocytosis, but they also create a problem in that it turns out there are an awful lot of patients who have the symptoms of mastocytosis, but when you go about actually trying to find these these tumors of mast cells in the bone marrow elsewhere, you can't find them. So what do you do when, so these patients, they wind up going to lots and lots of different doctors. Each doctor pays attention to only one particular superficial aspect of the disease or another, whatever fits in the doctor's bucket. And they acquire these problem lists, 57 problems long. So what do you do when it behaves like it's mastocytosis, but it's not mastocytosis and clearly not just allergic disease? What do you do when it looks like a duck, acts like a duck, quacks like a duck, but it's not a duck? Well, this is the situation where you clearly have to start learning and understanding, accepting, oh, there's this other mast cell disorder. It turns out to be extremely prevalent, something called Mast Cell Activation Syndrome, and you need to start at least considering it in the differential diagnosis where appropriate. Now, these are the diagnostic criteria, the consensus one diagnostic criteria for MCAS, and I don't have time to go through the details, but suffice to say, from all the red you can see here on the screen, that there are a lot of problems with these criteria. And these are the consensus 2 diagnostic criteria that are structured very similarly to how the criteria for mastocytosis are structured, in that you have to meet the major criterion. And in mastocytosis, that major criterion is having aggregates of mast cells found in one tissue or another. Here in MCAS, the major criterion is just having multi-system symptoms that are reasonably attributable to chronic inappropriate activation of the mast cells. And as in mastocytosis, you have to combine the major criterion with one or more of the minor criteria to make the diagnosis. And there are a number of options here, but not surprisingly, the option most commonly used to finish cementing a diagnosis of MCAS is simply finding laboratory evidence of mast cell activation. So there's increasing estimates of prevalence of MCAS. Honestly, the more recent studies are consistently showing 17 to 20% of the at least the first world population. And if you look back at the research over the last 20, 30 years in a lot of different chronic idiopathic inflammatory diseases, you can see the hints that with more and more of these diseases, it's becoming apparent that mast cell activation is critically involved in the pathogenesis of many of these diseases. It's just that nobody has been quite sure how the mast cells are wrapped up in this. Nobody has ever considered the possibility that maybe it's the mast cells that are actually the primary problem with these diseases. So that's research still to be done in each of these areas. So given that we now know most cases with MCAS actually are rooted in various mutations in KIT and other mast cell regulatory genes, the question then becomes, what portions of the populations bearing each of these inflammatory diseases might actually have a clonal mast cell disorder at the root of it? So just another slide on the clonality of this. We know there's a huge assortment of mutations in these mast cell regulatory genes in these patients. Haven't actually found any specific patterns yet. Every patient seems to have a unique mutational profile. Most of these patients have multiple mutations in KIT. But the problem in detecting these mutations on a regular clinical basis is that at present, the only mutation you can assess for in the clinical laboratory is that codon 816 mutation that is almost always present in the ultra-rare disease of mastocytosis and almost never present in MCAS. Don't have time to go into the details here. This is just all a sort of a catalog of all the different mutations found so far merely in KIT alone in different cases of MCAS. So you can just start to get a better understanding of the heterogeneity of this. So to go back and answer the original question, how does one disease present in such a dizzyingly heterogeneous fashion? Well, do the math. These mast cells produce and release not just scores, but hundreds of different mediators, and any one mutation merely in KIT alone. KIT is the dominant mast cell regulatory element. So any one mutation in KIT is going to drive the aberrant release of some number of mediators, creating some potential for multi-system illness in different fashions in different patients. But it's more complicated than this because it's not just one mutation in KIT. We know that most of these patients have multiple mutations in KIT, creating even more potential for multi-system illness and clinical heterogeneity. But it's more complicated than that because we know it's not just KIT that gets mutated. It's a multitude of other mast cell genes that also get mutated in these patients. And it gets even more complicated than that because each mediator that's getting inappropriately released doesn't have just one effect in other cells and tissues in the body. Each mediator has its own huge array of direct and indirect effects, local and remote effects, acute and delayed and chronic effects. And this is how one disease, so to speak, just in a zillion different genetic variants, is driving such a vast spectrum of multi-system unwellness and heterogeneity. So if it presents so differently in different patients, is there any way you can actually just sort of summatively describe it? And this is the best I've been able to come up with in my years dealing with this. It's a chronic multi-system polymorbidity of general themes that kind of follow along the lines of what the majority of the mediators do. Most of the mediators drive effects you would superficially classify as inflammatory effects. So chronic multi-system inflammation, that is the universal constant in MCAS. And then there's a plus minus on the allergic phenomenon. I say plus minus because it turns out there are a lot of these patients who don't have a speck of allergy to them, and then an unfortunate few at the opposite end of that spectrum who, honest to God, are suffering 24/7 anaphylaxis. And you can't even imagine the misery of those patients if you've never seen it. And then there's a plus minus, a third theme, plus minus. This is the hardest of all to recognize because many of the mast cell mediators are integrally involved in guiding growth and development in all tissues in the body. But obviously, these processes happen slowly. Thank God they're usually benign rather than malignant, but they happen slowly and they're usually pretty clinically insignificant. So nobody pays them any attention. But nevertheless, they're there, they're abnormalities, there has to be some reason for them. And mast cell disease can drive those issues too. So these patients typically present if you take a careful history in them, you can trace the symptom, at least some of their symptoms. You can trace back to at least adolescence, quite often even childhood, sometimes even infancy, and it's always multi-system. But that doesn't necessarily mean every system is going to be affected. It's always at least inflammatory. It's a perplexingly inconstant course. Externally, these patients quite often look perfectly healthy, but internally they feel like crap. Tryptase, great marker for the rare mast cell disease of mastocytosis. Tryptase is almost always strongly elevated in mastocytosis, but there are good reasons why it's usually normal in MCAS. So instead, you got to go looking for other mediators relatively specific to the mast cell to find the evidence of mast cell activation. But I'll be the first to acknowledge it is quite technically challenging at present to do this testing. You got to be sure you're handling the specimens properly. So unsurprisingly, with such mysterious and heterogeneous presentations, these patients wind up seeing boatloads of doctors. They get truckloads of diagnoses. They're tried on trainloads of treatments over the decades. Most of it doesn't work, and they often get dismissed and discharged and told they're psychosomatic. And put yourself in their shoes. If that's what's happened to you, you learn to shut up. You don't go telling your doctors about your symptoms, because if you do, they're just going to run the same tests that were already run 10 times before that found nothing and led to treatments that achieved nothing. You waste a whole lot of resources. It's not worth it. So you have to learn when you start to smell this disease in these patients that what they're telling you, what they're volunteering to you is only the tip of the iceberg. You got to go take a complete review of systems to extract out of them the stuff they long ago learned to not tell anybody. I want to also point out in the upper right-hand corner, this is the overall natural lifetime course of this disease. It's always waxing and waning to some degree, but from time to time throughout a mast cell patient's life, the disease can, not that it necessarily will, but it has potential to, it can fairly suddenly significantly escalate in the baseline level of misbehavior of the dysfunctional mast cells. But when these escalations emerge, and I use that word escalation to distinguish from just a flare of the disease, when these escalations emerge, they tend to shortly follow, anywhere from a few days to at most a few months, shortly follow a major stressor, either physical or psychological stressor. So that's the overall natural lifetime history of this. So I don't have time to go into the details of the presentation, but I want you to get the notion of the general theme here of system by system by system by system. It's inflammation, 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 inflammation. We call it by different words, but that's what it boils down to. It's inflammation, system by system by system. The GI tract, it's all inflammation. Boy, do these patients aggravate their GI doctors with their alternating diarrhea and constipation. And the women in particular always having their UTI, their so-called UTIs, but you often cannot actually find any infection in them. And it's not actually infection, it's interstitial cystitis, which the more avant-garde urologists are beginning to understand is often actually MCAS at the root of it. It affects the muscles, the bones, the joints. We talked about how the integument is an area where where these cells are dominantly sited, not just the skin. You know, you get hair issues, nail issues, oh, the dental issues galore in these patients. And these cells are also directly abutting neurons, peripheral and central. So no end to the range of neurologic and cognitive and psychiatric and dysautonomic issues you get in these patients. The hematologic issues are all over the map, although usually most of these patients have a normal CBC, which is a hard thing for hematologists to wrap their heads around because they think of this as a hematologic disease, and yet the CBC is normal, and that doesn't compute for many of them. The marrow actually is usually normal in MCAS. The immune system often is affected, poor healing, and a wide variety of other immune system issues. The endocrinologic and metabolic issues are all over the map. It just depends on which mediators are coming out of these dysfunctional mast cells in the individual patient. The growth and development issues are all over the place. And upon request, I've added in a few notes specifically on postural orthostatic tachycardia syndrome. So in some portion of the POTS population, is that disease rooted in certain patterns of chronic aberrant mast cell mediator expression? And we got more than a quarter century of tantalizing hints in the literature. But none of these have actually proven it. A few small studies have suggested an association between MCAS and POTS, but association is not the same thing as causation. Smoke does not necessarily mean fire, and there's going to have to be an awful lot more research to prove that certain variants of MCAS actually cause some form of POTS. And so then the question comes up, so if they're associated, how might MCAS actually drive POTS and, for that matter, other dysautonomias? Well, first of all, consider the relevant anatomy here. Where are the mast cells in the body? They're at all vascularized tissues, sparsely distributed in most tissues, but dominantly at the environmental interfaces and in the walls of all vessels and the sheaths of all neurons. So they're well positioned to instantly, markedly impact neuronal functioning. And then consider the biology of this. Are there do the mast cells produce mediators which can drive tachycardia? Not only tachycardia, but also the vasodilation you'd expect to see with drops in blood pressure. And absolutely, these cells produce lots of those mediators. So the potential for direct and indirect, even circular signaling, and signaling involving both abnormal mast cells and other normal cell populations is vast. And note that there's no requirement that the mast cells themselves inappropriately express a key mediator or its promoter or inhibitor. It may be sufficient simply for dysfunctional mast cells to over or under express a promoter or inhibitor of a key proximate mediator to driving the effects you see in POTS. And keep in mind, too, that it's a wide range of other dysautonomias that MCAS often drives too. Variations in temperature, pressure, flushing, sweat regulation, sleep regulation, glucose, and other hormonal balances. So which particular mediators might be driving this? And honestly, there are a lot of mediators. This is just a small subset of the list that can easily have impacts on all those other functions. So is it possible? There's been some thought about whether autoantibodies of various sorts targeted against relevant cardiovascular targets might be driving POTS. And MCAS itself can drive aberrations in the immune system, including spurring the emergence of various autoimmune diseases. So it's possible that MCAS might be at the root of some autoantibodies that are actually driving POTS, but there also are some pretty strong arguments against autoimmunity as a route to POTS. And a couple of ideas here. If certain autoantibodies are driving POTS, why is it that the kinetics of a POTS flare, how acute a POTS flare can be, that doesn't come anywhere close to the kinetics with which autoantibody titers fluctuate? So that is hard to explain. Is it possible that maybe the autoantibodies are part of it, that there is a complex multifactorial matter of relatively stable levels of cardiovascularly targeted autoantibodies creating a state of potential for flares of POTS, but then you need one more secret ingredient in the sauce, release of certain mast cell mediators, acute release of certain mast cell mediators to finally tip the patient over the edge into a clinically obvious flare of POTS. So complicated situation. Occam's razor obviously favors simplicity, just that it's just flaring of MCAS, no need for autobodies to get involved. But frankly, a whole lot more research needs to be done to either prove or disprove this. Now, if the mast cell-based somatic mutations, not germline mutation, we know from the research, most of these mutations in the mast cells are not inherited. They're acquired at various stages in the patient's life, and we're still trying to figure out why those mutations develop. But if it's these somatic mutations in the mast cell regulatory genes that actually are essential to POTS and other dysautonomias, what are the chances that standard whole genome sequencing will find these mutations? And the answer is minimal, because most sequencing will only pick up mutations that are present in 20% or more of the sequenced cell population. So most sequencing, you take a blood sample, you separate out the white blood cells, you sequence the white blood cells, and if you find mutations in more than 20% of those cells, you say, oh, we found these mutations. The problem is that the mast cells only comprise 0.02% of all the circulating leukocytes. And that's why you never see mast cells reported in a leukocyte differential in a CBC. So standard sequencing is not going to find these mutations. Instead, what you have to do is what those clever folks at the University of Bonn did starting back in 2007, when they found all these mutations, all these somatic mutations in the mast cells, in the regulatory genes in the mast cells. Because what they did, they didn't sequence a whole population of leukocytes. They first extracted the mast cells out of the leukocyte population, and they had a purified mast cell population. That's what they sequenced. And then at that point, they found these mutations galore. So that's what we're going to have to do. But presently, there's no clinical sequencing lab anywhere on the planet that offers mast cell focused sequencing. Can only be done in research labs at present. So fundamentally, we're going to have to get to a point where this sequencing becomes routinely available, and then over time we'll start being able to correlate, oh, these mutations are commonly found in these mast cell patients who have POTS, and therefore maybe it's one or another of these mutations that are driving the POTS phenotype. So that's where things are eventually headed, but it's going to take a long time to get there. So sorry, I'm running I only need about another 3-4 minutes here. Sorry, I'm running late, but you guys did ask for the POTS talk. Anyway, so such a heterogeneous disease, such a nebulously presenting disease, how are you going to diagnose it? You got to fall back on the physician's best friend, a complete H&P, and restore your faith in Occam's razor. I mean, yeah, the patient may have 57 problems on the problem list, but what's more likely, that all these problems are developing independently of one another, or one diagnosis that's actually biologically capable of causing most or all the findings? The simplest solution, that's Occam's razor, and that's obviously more likely. It's not a guarantee, but that's more likely. The astute diagnostician, of course, needs to still consider all the other differentials that the patient's symptoms might account for. And boy, are there a lot of them, including the inborn autoinflammatory syndromes that are a whole lot easier to do the genetic testing for now than it used to be even 10 years ago. This is the overview to the diagnostic workup. Again, we'll get into the details at a later presentation, but fundamentally, the top box here, you have to at least develop a clinical suspicion of it. If you don't even think about it, how are you going to diagnose it? And then you do the initial testing, which in many patients could be as simple as just checking a tryptase level. If it's way high, fine, go look for mastocytosis. But otherwise, you drop down into this bottom box and you got to go testing for these other mediators that we often find elevated in MCAS patients, but it is technically challenging testing. It's not that you can't do it, it's just you got to teach your laboratory people how to handle the specimens properly. So prognosis actually for most of these patients is pretty good. We know from the research, most of these patients are going to live a normal lifespan. So if you're going to live a normal lifespan, what it says in the red here at the bottom, if you're going to live a normal lifespan, obviously getting them an accurate diagnosis and then appropriate treatment that will get them to a better quality of life, this becomes very important because they're going to have a normal lifespan. Treatment, again, we'll get into this in the third of this series of 3 presentations later this month. But just a brief overview, the treatment largely is for indolent mastocytosis, and that's because the problems in indolent mastocytosis are coming from the activation of those malignant mast cells. So step 1 is to identify the triggers as best you can. Do your best to avoid them because it's kind of hard for any drug to gain good control as long as the patients keep exposing themselves to a trigger. So it's often hard to do, but you do the best you can. Some patients are more successful than others in that regard. You want to identify and avoid the triggers best you can. Keep in mind, these patients often are reacting adversely to medication products, but when that happens, it's almost never the drug that's causing the problem. Instead, it's almost always some excipient, filler, binder, dye, preservative that's actually triggering the reaction. You want to inhibit mediator production as best you can. And again, I don't have time to go into the details, so I'm just focusing on the bold here. You want to try to inhibit mediator release, what some people call stabilization of the mast cells. You want to try to block the release of any mediators that have been produced. This is not a cancer. You don't need cytotoxic therapy, chemotherapy for this. In theory, a bone marrow transplant might be able to help these patients, but you're not going to do that for any but the most severely ill patients. And those are the ones who would have the hardest time tolerating the very aggressive procedure that is an allogeneic stem cell transplant. So you don't do this except under in the context of a very carefully designed and monitored clinical trial, and I'll be shocked if that ever gets done. And finally, with regard to treatment, if these mediators do get out, they're going to cause downstream problems, and you got to deal with the secondary issues and comorbidities. So there are various complementary treatments, so-called natural complementary alternative treatments. Many of these wind up having various anti-inflammatory activities via the same pathways that the NSAIDs exert. There's some non-pharmacologic therapies that can be helpful to probably work because, again, the mast cells abut the neurons, as shown in these photomicrographs here. So if you change the way the neurons are behaving, there's a non-trivial chance you can change the way the mast cells are behaving, at least to some extent. This slide and the next one, just some of the chronic multisystem inflammatory diseases I've been finding in an increasing number of my mast cell patients. This is not proof that MCAS is what underlies each of these diseases, but it sure makes you wonder whether MCAS might be what's underlying each of these diseases in some non-trivial proportion of the patients that bear each of these diseases. Actually, this is a little out of date. My list now is almost 260. Research ideas, basically got to better understand these mutations and then start investigating the likely presence of MCAS in each of these chronic multisystem inflammatory diseases. So we need to pursue a lot more research, improve our diagnostic techniques, better understand the etiology, better understand which treatments are best going to help which patients, and we got to better educate everybody who's in the circle of these patients. So that's it. Appreciate your attention, and I'll be happy to take any questions, at least up until 2:30.
All right. Well, thank you so much, Dr. Afrin. That was extremely informative. Yeah, that's just lots of information here. So for all of the attendees, Dr. Afrin has also given us a copy of the slides, so we can also provide that to you because there is a lot of information there, and obviously you couldn't describe every little piece in there. So it's an amazing resource. So we will be providing that to you as well. It's also right now in the chat. There's a link to it in the chat too, but we'll also provide it in the follow-up email. So we do have just a little over 20 minutes for questions, and so we'll start with the ones most upvoted, and we will move from there. So when I call your name, I will be putting you up as allowed to talk. And so the first person, Raquel, are you ready to ask your question?
Yes, we've seen a lot of people with long COVID having symptoms that are compatible with MCAS. How do we go about working it up and helping?
Right. That's an important point. You're aware that there's a subpopulation of COVID patients in whom there's an unusually severe acute course of the disease, a so-called hyperinflammatory cytokine release, and why, and that's in about 20% of COVID patients. And why do those patients behave differently than the other 80%? And what I've been seeing in my experience the last few years of the epidemic, it's because those more severely, acutely affected patients, they have MCAS. And more important, it's not just that they have MCAS, but rather that they have unrecognized, uncontrolled dysfunctional mast cells. You don't have to worry about what the normal mast cells are doing in reaction to the virus. Those mast cells are reacting normally. You get some inflammatory symptoms for a week or so, and they settle down. That's that. The problem is that when you get these dysfunctional mast cells, there's something about the virus, whether it's a spike protein or something else, that is wildly overactivating these dysfunctional mast cells. So that seems to be what's driving the ultra severe course in a minority fraction of the acutely infected patients. And with regard to the long COVID syndrome, yeah, just like you, I've seen uncountable numbers of people who told me that before I got COVID, I was perfectly fine. But in truth, you do a deep dive into the history of every single one of those patients, you will find that no, they were not perfectly fine before. In fact, they had a long history of assorted symptoms, maybe not severe, but nevertheless, they had a long history of assorted symptoms that actually are quite compatible with MCAS. And you begin to realize that what long COVID syndrome actually, maybe not in everybody with long COVID, but nevertheless in a lot of long COVID patients, what long COVID is one of these escalations of pre-existing MCAS. It's just that it was unrecognized MCAS, and therefore it was undiagnosed and untreated and uncontrolled. And it's the wildly inappropriate reaction of the uncontrolled dysfunctional mast cells that then drives the escalation of the disease. They get a whole worsened set of symptoms that we conveniently just call long COVID. It's been interesting. You can imagine, I've been falling down this mast cell rabbit hole for like 16 years now. So many of my patients were diagnosed with MCAS well before COVID came out. And, given how widespread the virus is, how contagious it is, of course, many of my patients already diagnosed with MCAS and treated for MCAS. Of course, many of them came to incur COVID infections, but it's been interesting that not a single one of them who had already been diagnosed and with MCAS and effectively treated, not a single one had one of these ultra severe acute cases, and not a single one developed long COVID syndrome. Instead, those people, they have a modest course of the acute virus. They get over it and they get back to their prior baseline, whatever that was, with their controlled MCAS. So you're very reasonable, I think, if you see somebody with long COVID syndrome. I mean, why does the symptom spectrum for long COVID seem to overlap with MCAS? Because it's probably MCAS that's what's driving those symptoms. So you're very reasonable to suspect MCAS in your long COVID patients, but that, of course, doesn't prove it. So I still recommend you pursue the diagnostic workup for MCAS. And again, we'll talk more in detail about that at the next presentation.
All right, well, thank you so much. And our next person, Athena Hall, are you ready to ask your question?
Thank you. I'd like to know, does your treatment approach differ for patients with biomechanical issues such as craniocervical instability, thoracic outlet syndrome, and situations where there's one significant driver among others, such as infections, for example?
Yeah. Those patients with the biomechanical issues and the significant infections are particularly challenging patients to treat, because if you go trying to address those other issues, if you try to take them through surgery or try to treat their infections, then the odds are high that the uncontrolled mast cell disease is going to make it tough for them to recover from surgery. You're probably not going to get the results from the surgery you might expect, and you try to treat the infections, and they might well just start reacting right out of the gate to pretty much everything you try to give them to treat the infection. So it's a much more nuanced affair. I mean, hell, it's a nuanced affair treating these patients under the best of circumstances, but particularly in those subgroups you described, it's even more of a nuanced affair. You got to try to edge forward, try to get at least some control over the mast cell disease, even though you're never going to get great control, because it's the biomechanical stressors and the infections are themselves just serving as additional triggers of the mast cell activation. But nevertheless, you try to get a little bit of control over the mast cells, then maybe move in with more treatments for these other issues, and then when they get better, from at least a little bit better from those other things, then you can come back with a little more mast cell treatment. And it's a highly nuanced affair. The approach is unique in every patient. I don't know what else to tell you about that.
Thank you.
All right, so then our next question comes from Daniel H. So Daniel, are you ready to ask your question?
Yeah, can you hear me?
Yes,
Yes.
sir.
Okay, my question is, have you found there's a strong association between MCAS and gut dysbiosis or other, sort of abnormalities in the gut microbiome? And does there seem to be causation either direction? And sort of what implications does this have for treatment? For example, if someone's found to have gut dysbiosis, what implications does that have for MCAS or vice versa?
Yeah, this is another one of those other subpopulations, or boy, do they take a lot of nuanced treatment, because it's probably the mast cell activation that led to the dysbiosis in the first place, the small intestinal bacterial overgrowth, SIBO, or small intestinal fungal overgrowth. But then again, you get these imbalanced microbial populations, and there's no question they put out a lot of substances that can impact the mast cells and probably hit on the dysfunctional mast cells a lot more significantly than normal mast cells. So again, it's going back and forth that's important with the treatment, but you got to understand, at least in those dysbiosis patients who also have MCAS, it's important to identify the presence of the MCAS and try to deal with it as best you can, because otherwise you can go treating these patients till the cows come home for their dysbiosis, and you're probably not going to make much progress. For example, a lot of these patients come to me having previously been diagnosed with SIBO, and their doctors have always given them one, often more than one, 2, 3, 4 week long courses of very expensive rifaximin, and they not always, but often show mild improvement while they're taking the rifaximin, but then within days to at most a few weeks after finishing the course of the antibiotic, their symptoms are right back to where they were to begin with. And that's because the underlying issue, the MCAS, was not recognized. It wasn't addressed, wasn't controlled. And the other thing you got to understand in that situation is that a lot of antibiotics actually have not only well-recognized and proven antimicrobial effects, microbicidal effects, but they also have, not every antibiotic, but a lot of antibiotics also have anti-inflammatory effects that are completely independent of their antimicrobial, microbicidal effects. And rifaximin is one of those antibiotics. So if you give somebody, an MCAS patient, who by definition has chronic multi-system inflammation, and you give that patient an anti-inflammatory drug, who's going to be surprised if they get at least a little bit better while they're taking that anti-inflammatory treatment? And then you take the treatment away, and who's going to be surprised that they pretty quickly go back to the same inflammatory baseline they were at before? So it's, I mean, you guys know as well as I do, you don't find patients who are more complex than these patients are. And everybody's looking for easy answers. There are no easy answers for complexity like this, but your best chance at finding some answer that will get these patients to a sustained better state, it has to come first from understanding as clearly as possible what's actually wrong with them, what's at the root of it, and understanding the MCAS part of it is, and addressing it is a big part of getting these patients better.
So as a follow-up to that, so in terms of a root issue, you talked about neuro, then upstream from MCAS, and then the downstream issues. And in the disease, any number of the diseases listed in your 260, but looking at COVID specifically, whether it's the spike causing inflammatory start or something else, the conceptually in the cells themselves, and constantly in the body, you've got the balance between the M1 and M2 white blood cells, the killers versus the builders, and presumably there's an imbalance towards the inflammatory killers, and whether it's driven by the MCAS or a combination of various things. And so if that is the case, then the trigger can start a process of inflammation, but inflammation itself can drive microcirculation hypoxia, which drives further inflammation because of putting the HIF-1 into the nucleus and spitting out chronic cytokines and turning into senescent cells that are basically little inflammatory widgets. And
yeah, whether it's hypoxia or any other mechanism, yeah, the downs, don't go thinking for a moment that it's only the mast cells that are misbehaving in these MCAS patients. It's a huge range of cells that are misbehaving in these patients. The issue is, where's the root of the problem? And
along that route, that's where the core of my question is going, is so if there is a local autonomous microcirculation problem that's MCAS driven, inflammatory driven, some combination, is hypoxia putting HIF-1 into the nucleus, and that's the driver of genetically putting out cytokines, or is something going the other way, like some of the MS drugs that get NRF2 back in there, and so you're then tipping towards the M2. How important is it to try and stack different interventions simultaneously that might be hitting the virus, the inflammation, the MCAS, the platelets, the TLR4, nanokinase or something to break stuff up versus doing them kind of one-off or sequentially? And is it sort of like cancer was?
Well,
Not cancer as treatment. I mean, cancer as treatment where multiple drugs together work
Yeah.
much better than one alone.
And you are right that almost every single one of these patients is ultimately going to require a cocktail of treatments to get them to whatever happens to be the best state that they can get to. That having been said, I will tell you too, I learned a long time ago with these patients that if either the patient or the doc starts making 2 or more changes in the regimen around the same time, and then they get either better or worse, you have no idea which one is actually making them better or worse. It is a holy mess to sort it out at that point. Yes, I will acknowledge that everybody in life from time to time faces urgencies and emergencies where the patient and the doc have no choice but to make multiple changes in the regimen around the same time. That's life and you deal with it. But as much as is possible, one change at a time. And honest to God, what I've seen is that for the vast majority of the drugs that make biological sense to try for MCAS, it's not 100% of all the drugs, but almost all the drugs that make biological sense to try for mast cell disease, honest to God, it does not take any longer than about 2 to 4 weeks to figure out whether that particular drug, in other words, that particular molecule is going to be the right molecular key fitting into the particular molecular lock that just happens to be that patient's particular variant of this highly variable disease. It doesn't take long at all. But as much as possible, patient and doctor have got to have the patience to make one change at a time. And keep in mind, too, that when they have these adverse reactions, and particularly if they're kind of unexpected, that the character of the reaction is not what you would predict based on the known mechanism of action of the drug. Oh boy, do you have to go suspecting excipient-based reactivity. So you don't give up on the drug, you just give up on that formulation. You look at the ingredient list, you try to figure out which excipient is the troublemaking trigger. And I'm well aware of how difficult this is, but you try. And then you work with the pharmacist, find a different formulation not containing the suspected offending excipient, and you try them on the other formulation. And if they have a better experience with that formulation, you just proved it's not the drug that's the problem, it's the excipient. And at that point, by God, it's the excipient that goes on the allergy list, not the drug. And frankly, at that point, the pharmacist then has another job to do because he's got to go looking at the full ingredient list for everything else the patient is taking to make sure they don't contain even a trace amount of that triggering excipient. Because let me tell you something, these patients can easily go. I'm not saying they're all this sensitive, but they have potential to. They can easily go from looking and feeling the picture of health to looking and feeling like death warmed over within minutes, sometimes even within seconds of exposure to even a trace amount of these triggering excipients. And when you see that happen, that's when you start really appreciating, really respecting the potency that these mediators in such tiny, coming out of these this small number of cells in such tiny quantities, and oh my God, the magnitude of the clinical effects they can have. And that's also when you start appreciating just how sensitive these dysfunctional mast cells can be to reacting to the tiniest amounts of some of these triggers. So watch out for that when you treat these patients.
Okay, I
That's
think
great.
we might have time for only one more question. So Anita Jane, are you ready for your question?
Yes. Hi, Dr. Afrin. Thanks for your talk today. Have you ever seen instances in which the MCAS might be downstream of other processes, such as maybe LPS translocation as a result of the microbiome dysbiosis, or as a result of like cardiolipin release from mitochondria, and like having those like then bind to a surface receptor on a mast cell, and then triggering the aberrant behavior that you see?
You are absolutely right that that is a possibility. And the only way you can tell for sure in the individual patient is to go take a careful history. And if you then start to find all sorts of other problems in the patient going way back earlier, to points in the patient's life well before they could have ever begun developing any issues affiliated with the more superficially apparent issue, and there's no way those LPS antibodies or antiphospholipid antibodies could have been present, decades ago, causing any of these totally other clinical issues they were having at the time, then you begin to realize that one of two things are going on. Either their LPS or antiphospholipid, whatever their antibody is, either it's something that has come about completely independently of whatever was long going on in them to drive all the other issues, or maybe what's going on is that the antibody is just another consequence that has evolved out of the misbehaving mast cells' impacts upon the humoral immune system. And actually, we've come to find that one of the most common impacts of mast cell disease on the immune system is to drive the humoral immune system into this wicked sort of overdrive, producing all manners of antibodies that the immune system has no legitimate business producing. And actually, many of those antibodies, they're entirely randomly produced antibodies. And as you might imagine, you produce enough randomly produced antibodies, and some of them just by chance, they're the three-dimensional structure of their FAB fragment, their antigen recognizing fragment, are just going to come to resemble the real antibodies that you would really get in a real infectious or autoimmune disease. So we often get false positive readings on a huge array of infectious and autoimmune antibody testing in folks with mast cell disease. And you have to take a careful clinical look at the patient, and you realize, no, this patient does not have that infectious disease. They don't have this autoimmune disease. They just have mimicking antibodies. And I can't tell you how many times I've seen well-intentioned clinicians who just don't understand MCAS or these antibody issues yet, and they are desperately trying to help these mysteriously ill patients. They run all these antibody tests. They get this mildly abnormal level. Usually it's mildly abnormal. Occasionally it's totally gonzo, off the scale abnormal, and yet you look at the patient and say, my God, they should be way sicker than they actually are. And you realize too, and it's just like how the mild abnormality doesn't line up with the degree of severity of their disease, these super high antibody levels don't match up either. And you realize you're looking at mimicking antibodies here, but sometimes these physicians, they're desperately trying to help these patients. They make a diagnosis the patient doesn't really have. They start treating these patients, and at best, that's just not going to help anything. But at worst, you could cause a lot of medical and even financial toxicity. So I'm not saying that, mast cell patients can't get infections or can't get autoimmune diseases. I'm just saying you got to be careful in how you go about diagnosing those other diseases. In general, you want to go diagnose an infectious disease in a mast cell patient, you better go either getting a positive culture or finding the DNA sequences through PCR or FISH testing that are the DNA sequences that are unique to the genes that are unique to each and every different microorganism. And for the autoimmune test, they better have a fairly classic presentation of that autoimmune disease. And you want to see the patterns in the antibody titers over time that are they kind of make sense, what you'd expect to see for that disease. But many times you see these antibody levels in mast cell patients that they're mildly positive and then stone cold negative and up and down and up and down and up and down. And it's not correlating one bit with what's going on clinically with the patient. And you begin to realize, nah, that's a mimicking antibody. That's not clinically significant. So it's tricky. There's no easy answers for these patients. Thank you for the question. Great question, but I'm sorry. I do have a patient waiting for me now, and I'm going to have to go.
Yes. Thank you so much, Dr. Afrin. We look forward to seeing you on the 22nd for part 2. So that we're very excited about that. And yeah, for everybody that is attending today, we will try to address more of these questions for then, and then also we'll send you also the link to part 2 as well. So if you
Yeah,
haven't yet signed up, please do.
The next sessions are on Saturdays, so I've got no constraints on my time on Saturdays. So, all right. Thanks a lot, folks. See you next time.
All right. Thank you. All right. And thank you everybody for attending. And we will send you the PowerPoint slides, as I said, after in the follow-up email. And then, yeah, and then we look forward to seeing you again on part 2 on June 22nd, which, as Dr. Afrin said, is a Saturday. So he's got more free time on that to really go in depth with a lot of these questions. So because you guys have some really amazing questions in here we just couldn't get to. So we will see you then. Right, thank you everybody so much. I don't know if any of our panelists have any other comments you want to say before we leave?
All set. Thank you, everyone.
All right. Well, thank you. Have a good day.